Thank you very much for the introduction. And it's my pleasure to be here today to speak in this workshop again. And today I'm going to give you the update on the Thailand situation, and especially we'll focus on the two models, the key population-led model and the online technology-based models. In 2015, Thailand has achieved 89, 70, and 82% according to the 1990 targets, which results in only 51% of total PLHIV who had viral load suppression. And that supports that we still need an urgent innovative models to actually achieve the NDH goal within the next 15 years. So I will start with the key population-led test and start and prep service. Even though this is 1990 thing, I think we cannot don't talk about prep. Is you are going to focus on the key population. I feel that it's just the same package. And within this key population-led model, the Thai Red Cross AIDS Research Center has worked with support from USAID PEPFAR with 7 drop-in centers in 4 key provinces with MSM and TG. And MSM and TG contributes to around half of new HIV cases each year in the country. And in this program, we aim to strengthen capacity of community staff who are non-healthcare professionals but are members of MSM and TG communities for them to be able to provide HIV testing, to provide STI screening, and also to provide PrEP. And this is just beyond the role of them being outreach worker, distributing condoms and lubricants. And so the community health workers here have been trained to do finger prick blood collection and use blood collected for HIV testing, syphilis testing, and CD4 count. And they can also collect samples for STI screening. And the latest addition is to have the capacity built to provide PrEP to their clients who visited the community health centers. And ongoing trainings and coachings and also QA/QI activities are conducted by local public health facilities. And the provincial health office in these key provinces now consider this community health center or drop-in centers as part of the official HIV service delivering unit in each province. And just to show you some numbers here to show that this key population-led model is actually feasible and also is very effective in reaching out and then bridging high-risk MSM and TG into the program. Over a 1-year period, we enrolled around 2,000 MSM and TG clients, and 17% tested positive. Sorry for not very nice slides here. 99% of those tested positive accepted to start immediate ART, and 83% started ART effectively. And among those who started ART successfully, the median time between between HIV diagnosis and ART initiation is only 15 days. And at 6 months after ART, 82% already achieved viral load less than 50, and 92% achieved viral load less than 1,000. And we can also demonstrate that with the key population-led model, we diagnose people at much earlier stage than compared to the conventional model. Here you can see that more than 50% of those who are newly diagnosed in the program had CD4 count above 350, which is much higher than the median CD4 count at ART initiation at the country level of just above 100 cells. And we are moving towards having this key population-led model not only be the test and start, but also be the key population-led PrEP model as well. And since October last year that we started to offer PrEP to HIV-negative clients in the program, 54% of them accepted to be on PrEP. And we have now expanded the key population PrEP model into a larger population of MSM and transgender population as well. And this is feasible through the availability of the Princess Somsawali HIV Prevention Fund, which is the public donation fund to the Thai Red Cross AIDS Research Center. And our princess has been kind enough to provide her blessing quote to the communities. I talked about this this morning, that even though this is not legalized, having key population staff providing PrEP, but we have the royal support. So this is one thing that keep us on going while we are waiting to make things accredited, make things legalized in the near future. And under this program, we have almost 300 MSM and TG who access PrEP within just 3-month period. And we plan to expand PrEP access to 1,000 MSM and TG per year in the next 3 years while waiting for the countries to get the cost utility results and then integrate PrEP under the national healthcare schemes. And in this program, we have close collaboration between CBOs and also local public health authorities, and the experience learned has actually led the country to move forward to expand the facility-based PrEP program in other additional provinces as well. And I just would like to talk a bit about demand generation for PrEP because we know that the key populations that we are talking about here, they engage in online risk and then to meet together offline to take a risk. So how can we change that into we engage them online to get them interested in the service and then transfer them or bridging them successfully to get the offline services. So in this program, we have the Adam's Love website, which is a very successful website. We reach more than 3 million MSM already over 4 years period. So we, during the first 3 months of this year, we reach out to high-risk MSM and TG online, provide education around PrEP, and then those who are interested in getting the service, then they do online booking, and they get the ticket and the QR code, which they can then use to present to the clinic to receive the fast-track HIV testing and PrEP services. And only during the 3-month period, 425 people booked online. That's not very interesting, but among that 425, 76% actually presented to the clinic, and half of them started PrEP. So I think that this is a very feasible model to be scaled up. And the online technology here, we can also use it to support the HIV testing step. And this is the model that we are testing with the support from AMFA. We call it online supervised HIV self-testing. And this is feasible by using the online platform, which provides you a private and secure space for the counselor and the clients to meet together online and go through all the process of the self-testing online in their own privacy, but with real-time supervision provided by the trained counselor. And we have seen that this model compared to conventional model, we have reached those who never been tested before more than the conventional model, and so reach those who have very high prevalence of HIV, especially if this is done by community health workers. And lastly, the online technology can also help us to monitor and improve the HIV cascade. And this is the e-cascade model, which is piloted by linkages in several provinces in the country. And it allows us to track HIV referral from outreach to HIV testing and to ART clinics real time, so that we can identify which points that we have to intervene. And also this can help us identify high value social networks for recruitment as well. So in conclusion, we have demonstrated here that it is feasible and it is very necessary that we establish and we nurture the key population-led models and also online technology-based model. And we are so impressed with how our community colleagues shows their enthusiasm and be proud of having their capacity strengthened to perform or to provide services in these models. And the next step is to address structural barriers to institutionalize and finance these models and to extend it to the other key populations, such as youth and people who inject drugs. Thank you very much.